Good afternoon, sir. How are you?
Very well. Go ahead.
Okay. So this was a last minute change. Actually, this talk was supposed to be given by Dr. Radha, actually. So I was handed over this talk only yesterday. So instead of talk, I'm just going to present a couple of cases that we have done in a case of percutaneous pulmonary valve with bilateral branch PA stenting. So the first case, this was a 12-year-old boy weighing only 26 kilos, was a case of transposition TJ, VSD, and pulmonary atresia. He underwent a rastoly with a 16 millimeter bovine pericardial conduit and a MAPCA unifocalization. Subsequently underwent a bilateral branch PA stenting into the RPA and left lower lobe of the branch of the left pulmonary artery. Now presented to us with an RV to PA gradient of 60, the conduit gradient of 60 millimeters of mercury, and right pulmonary artery gradient of 30. LPA we checked, there was no significant gradient. We evaluated this patient for feasibility of percutaneous melody valve, and during that cath, these were the findings. This was the echo. You can clearly see a dilated right atrium, right ventricle, and this is the TR gradient, which was coming around 70 millimeters of mercury. So RV systolic pressure was definitely high. And this was the conduit with a degenerated conduit with a stenosis and regurgitation, the gradient around 60-64 millimeters of mercury. So we did a CT. You can clearly see this calcified conduit and see the stent in the right pulmonary artery, a significant narrowing, though the distal right pulmonary artery seems reasonably well. And the left pulmonary artery stent was also narrow, and you can see clearly identify the fracture of the stent as well. The narrowest diameter of the conduit was around 13 millimeters, and the length of the conduit in both the measurements was approximately in the lateral and in the RAO projection was around in the lateral was around 30 millimeters. In the RAO projection, it was coming around 40 millimeters. So length was not an issue. So it's a fairly long length with a significant narrowing. And in this CT image, you can clearly see the left coronary artery very close to the distal calcified narrowed segment of the conduit. So this was a major cause of concern in this particular patient. So we thought we'll with the balloon occlusion. We did a compliant balloon occlusion, ASD sizing balloon occlusion to check the left coronary artery. Though it was very close, but there was no significant compression of the left coronary artery. The right coronary artery was far away from the narrow portion and the calcified portion of the conduits, and we checked that as well, and there was no significant compression of the right coronary as well. So we planned this patient for percutaneous pulmonary valve, and before that we thought we'll do the dilatation or stenting of both the branch pulmonary artery, check the gradient across and do that. So this was the RV angiogram in the RAO and the lateral view. You can clearly see the heavily calcified conduit and the narrowing of the right pulmonary artery and the left pulmonary artery. So these stents were implanted very early in around 2009, 2010. At that time, we had only renal stents available for the implanting. So this was a we didn't know, we don't know how much they will go further. So we gave an attempt, we crossed the right pulmonary artery, we crossed the left pulmonary artery. We initially dilated with a 8 millimeter ZMET balloon, but nothing happened. And then subsequently we dilated with a high pressure, with a 10 millimeter conquest balloon. We inflated up to 20 atmosphere of pressures. And subsequent to this dilatation, we checked the gradient. There was no significant gradient across the right pulmonary artery. And then we crossed the left pulmonary artery stent as well. As you can clearly see, it was implanted because this was a unifocalized left pulmonary artery and the right as well. So the length was not very significant. We got a reasonably decent wire position. But whenever we tried to take a balloon across it, we were not able to cross that because of the angulations and all that. And since we had checked the gradient before, we thought there was no significant gradient across this narrow segment. We thought we'll balloon it, but unfortunately, because of the angulation and all that, we were not able to take across the balloon across the left pulmonary artery. So we left it like that, and subsequently we did a compliant balloon testing of the, we checked the coronary artery, and we thought of pre-stenting the conduit with a covered stent. we planned for that. And we put a catheter in the left coronary artery, checked it in both RO and the lateral position. Subsequently, took a 14 French sheath, Mullin sheath across the conduit by placing the wire in the right pulmonary artery. And we took a 45 millimeter mounted on a 16 millimeter ZMET balloon across the stent, and as you can clearly see, the whole length of the calcified segment that's seen on the fluoro is reasonably well covered. And once after doing a check angiogram, we inverted the stent, both the right and the left coronary artery, and there was no significant compression of the left coronary artery. So subsequently, we post-dilated this stent with an 18 millimeter ZMET balloon and followed by a 20 millimeter Atlas Gold balloon as well. And we checked the coronaries because you can clearly see at the distal part of the stent, there is a significant narrowing. So we thought of getting rid of the narrowing before implanting the valve. After dilatation with a 20 millimeter Atlas Gold balloon also, we checked the coronaries, there was no compression and it was reasonably well open. Checked the angiogram, there was no significant narrowing, no gradient. We checked the hemodynamics, there was no gradient across the RVOT. Subsequently, we took a 18 millimeter Melody valve implanted on a 22 millimeter ensemble. And after checking the positions in both RO and lateral view, we implanted in the lateral view. This is the implantation. And we check the right and the left coronaries both. This is the left coronary artery and this is the final angiogram. The post Melody valve implantation, there was no gradient from the right pulmonary artery to the main pulmonary artery was only 5. From the pulmonary artery to the right ventricle was only 50 meters of mercury. The RV systolic pressures were 30 as compared to the aortic pressure, femoral artery pressure of 130. So it was a reasonably good result. This was the second case. He was a 19-year-old male post-truncus repair done in 2002. And during the repair, there was no left pulmonary artery. So the truncus repair with a single lung was done. And subsequent, because of the RPA narrowing, RPA stenting was done in 2005. Subsequently had degeneration of the conduit and 21 millimeter perimount valve was implanted along with the removal of the stent and bovine pericardial repair of the conduit along with RPA plasty was done in 2012. Now presents with bioprosthetic valve dysfunction with severe stenosis gradient of 64 millimeters of mercury. We did a CT angio to that. There was a single left coronary artery which trifurcates into the LAD circ and the right coronary artery. And also the right pulmonary artery at the origin was significantly narrow. It was around 9 millimeters, whereas the distal right pulmonary artery at the hilum was around 16 millimeters. There was significant narrowing of the right pulmonary artery. So this was the angiogram, pre-angiogram and the left coronary artery angiogram prior to the procedure. And as you can clearly see, there was significant narrowing of the right pulmonary artery on angiogram, but on pullback, there was no significant gradient across the right pulmonary artery. But the main pulmonary artery to the RV pullback gradient was around 67. So we thought we'll just do a balloon dilatation because it was definitely appearing narrow for a single pulmonary artery, and we thought the gradient, we might be underestimating the gradient in the presence of the proximal stenosis. So we thought we'll just dilate it with the balloons. We initially did a right pulmonary balloon dilatation with a 16 millimeter balloon. You can clearly see that we could feel that while inflating, there is significant narrowing there. So we thought of implanting a stent, but simultaneously we did a balloon occlusion of the combined balloon occlusion of the valve and check the coronaries as well. Though in CT there was no significant, but as a protocol we checked that, and there was no significant narrowing. So then subsequently we implanted a CP stent, a bare stent, 34 millimeter mounted on a 16 millimeter balloon in the origin of the right pulmonary artery. And as you can clearly see, there was significant tight wasting of the right pulmonary artery at the origin, even with it was not going. So we thought of post-dilating it with a 18 millimeter balloon, and that's what we did. And subsequently, we could get rid of that. And then we took a 18 millimeter valve and mounted on a 22 millimeter ensemble and implanted it across the degenerated bioprosthetic valve. So this was the final coronary angiogram and the final angiograms in both the lateral and the RO projection. You can clearly see there was no obstruction, there was no pullback gradient from the RPA to MPA, and from MPA to RB, the pullback was only 16 millimeters of mercury. This is a fairly reasonable result. So the idea is any gradient across the valve or distal to the valve affects the durability of the valve. If you leave a gradient, the valve tends to degenerate early, and also it carries a higher increased risk of infective endocarditis. So any gradient distal or post-procedure as well, we should deal it before sending the patient home. Thank you.